I was going through treatment after treatment. Now I know were not only not helping me, but they were making my OCD worse. I could not fathom the fact that I had went 25 years of my life never being, one, diagnosed with OCD on my own, or two, being told of this one treatment that supposedly was supposed to be the most researched, evidence-based, efficacious treatment for OCD. Unfortunately, a lot of information is being talked about in an inaccurate way. The reason I do this is because I have lived experience, and the reason that I'm so passionate about teaching and educating other people on these concepts and these fallacies and the way that people like me, I have been one of those people that has been victim to misinformation, and I have lost many years of my life and a lot of quality of life as a result to it. This disorder can warp our minds, and it can feel like treatment won't work for us and that we're not worthy of treatment. I felt that, and I still have intrusive thoughts about that some days, and I'm grateful to myself for not quitting, and I hope that you give yourself that compassionate chance too, because you deserve it.
Welcome to the Get to Know OCD podcast. My name is Tia Wilson, and I'm a lived experience advocate for OCD, which means I'm someone who's had OCD my whole life and have found a lot of recovery through treatment, and now I advocate for others to do the same. I'm joined today by my lovely friend, Chatterjee. She is a researcher and a neuroscientist, and I would love for you to tell the audience a little bit about what you do.
I am Uma. I am first and foremost someone who lives with OCD, and my lived experience and my survivorship is what really motivates and underpins everything I do and the way I show up in the world. So I am a neuroscientist. I am earning my PhD in neuroscience at the University of Wisconsin-Madison, studying the biology of OCD and how it works in our brains, as well as novel treatments. I am also an advocate for the International OCD Foundation. I am vice president of OCD Wisconsin, and I am a science communicator and advocate on my podcast, A Chat with Uma.
Incredible. I'm so glad that you're here. Today, we're going to be talking about specialized treatment, which I know the reason I brought you on is because I know this is something that's really important to both of us. We both, as we mentioned, have OCD. We've both gone through treatment for OCD. We've both gone through poor treatment for OCD also. And so we're really passionate about helping people find what actually works. Let's start maybe with the poor treatment. Let's talk a little bit about what that looked like for us. Kind of, what was it when you first got diagnosed, or even prior to being diagnosed? What sort of treatments were you seeking out? What professionals were you working with? And yeah, how did that go for you?
Yeah, so I, according to my clinicians and me, was born with OCD, given the severity of my symptoms and how it governed my life for as early as I can remember. And I went 13 years with no treatment or diagnosis of any kind, because I think it's important to say, for many people who come from backgrounds like me, I am a Indian immigrant. I was raised in a household and a culture where there was absolutely no awareness of mental health or mental illness, and all of my symptoms were kind of seen as more of a byproduct of me being like something wrong with me as a person, as opposed to having an illness I struggled with. And so it got to the point with my OCD and my other diagnoses where I started attempting on my life, unfortunately, and I was institutionalized. And from that point, 13 onwards, I was diagnosed with major depressive disorder, generalized anxiety disorder, and panic disorder, all of which I do have, but was not diagnosed with OCD, nor did I have the wherewithal or understanding of what the disorder is or how to explain my symptoms and how I was feeling, because I believed all my thoughts and I didn't know what compulsions were. And so from a number of factors, I just wasn't diagnosed. And because of that, I was going through treatment after treatment that was not working for me. And even if they did work for my other disorders, now I know, were not only not helping me, but they were making my OCD worse. And I felt so hopeless. I felt so helpless. And I felt like there was just something deeply, fundamentally wrong with me, because what I was being told was psychological treatment, things like traditional cognitive behavioral therapy, psychodynamic therapy, EMDR, or eye motion desensitization and reprocessing. So many different treatments that just did not attack OCD for me or even identify what OCD was. And then it got to a point where I was so fully dysfunctional. I finally, because of myself and Googling my symptoms as a 22-year-old, I finally thought maybe I had OCD, even though I did not understand what it was and thought it was a, cleaning, quirky disorder. And it isn't, obviously. But after going and bringing that diagnosis to a clinical psychologist, because I thought that qualification would mean that they would be able to help me and they knew what to do, and all of that, I still received incorrect treatment for 3 more years, being told that it was helping my OCD and it wasn't. Continually got worse, was extremely suicidal, and finally finding evidence-based treatment, finding the gold standard first line of treatment for OCD, exposure with response prevention, like it almost felt like some sort of trick was being played on me, or I was just like, I could not fathom the fact that I had went 25 years of my life, at least, 12 years in the mental health care system, never being, one, diagnosed with OCD on my own, or two, being told of this one treatment that supposedly was supposed to be the most researched, evidence-based, efficacious treatment for OCD. It was so hard to get myself to actually do it because it felt like a hoax, truly, especially with how sick I was. And ultimately, long story short, I'm here at Save My Life, and everything you just heard about me as my introduction is because of recovery and how life-saving this was. But yeah, it is so heartbreaking and devastating to me that I lost so much of my life and suffered for so long because of getting incorrect treatment that made my OCD worse. And we need to do something about it.
Yeah. Well, and isn't it so fascinating that, you said people didn't recognize the weight of it until you were attempting your life, like until it was at such a point that you didn't feel like there were alternatives. Like, unfortunately, I feel like that's the case for so many people, where even internally, even if others aren't telling them that, they'll tell themselves that of like, yeah, I don't deserve treatment because it's not that bad yet. And the reality is, no matter how significant the symptoms are, like if there's something that can help you, that's been proven to help you, you deserve to know about it. And you deserve to know that's an option for you, like, let alone be able to access it. Cause yeah, I had a very similar story. That's one of the reasons we're friends, is because we've both experienced so much of that. But one thing that I find really interesting that was a contrast between our stories is you mentioned that, people viewed it as something that was wrong with you. And on the other hand, a lot of my symptoms were really praised by my community. Like I thought there was something wrong with me, but everyone else was like, wow, she, because of scrupulosity, I was so religiously devout. I was, always getting great grades because I didn't think I could do anything else. And I was so compassionate and kind. And I'm sure you've heard some of this too. It's not really that much of a contrast, but I was so compassionate and so kind, but really I was just so scared of hurting people. Right. And so that was one of the reasons I was kept from treatment, was that people just thought I was thriving. And internally, I was in such inner turmoil because this was driven by so much guilt and shame and just fear. And eventually, was able to get proper treatment. It wasn't until I had a chronic illness that I was able to kind of access therapy, because it had manifested, I think, in like a lot of physical ways for me. And at that point, I also went through EMDR, and I went through cognitive behavioral therapy and a lot of these similar treatments to you that are not treatments for OCD, right? And unfortunately, not only didn't help the OCD, but did worsen symptoms. They became like a further source of compulsion for me, right? Which only makes the OCD more significant. Went through a lot of misdiagnoses, a lot of treatments that can't even begin to touch on being helpful for OCD. They're not even related. And just felt very, very stuck. And I had a similar time where I just, for some reason, thought, what if this is OCD? There wasn't any reason for me to think that, because I was just as embedded in the stereotypes as you were of like, it's just a clean disorder and I'm a messy person and there's no way this could be me. But had that same thought, what if this is OCD? And luckily was able to find a therapist who specialized in OCD. And I think that word specialized is often thrown around and misused. A lot of times when therapists are like advertising their services, they don't need any credentials to say the word specialized. They can just go on and say like, I specialize in this. And maybe that to them means they treated one patient who had it, or they did a couple case studies in college. But let's talk about what specialization actually means, why that's important. And I'd love to have your perspective as someone who works in academia and, sees all of the work that goes into specializing in something. Like, what does that term mean to you?
Everything you said is so important to talk about what specialists aren't, because the reality is, whether it's a therapist who is going through more of the channels that exist for them to advertise themselves, the traditional channels like Psychology Today or anything like that. You can just name whatever you want to and say that you specialize in it. You can, there's no actual formal training or certification to do that. But then even more so to me on an egregious level is how people call themselves specialists on things like social media and how that's taken as truth when literally anyone can say anything. And that goes for being a specialist or otherwise, because the reality is a specialized provider or a specialized clinician or a specialized anything relates to being an expert in treating that disorder. In the case of specifically OCD or any other psychological or psychiatric condition, it's someone who has gone through supervision and rigorous training of the particular modalities that are targeted toward that specific disorder. We can liken it to a medical provider being a specialist for a certain condition or even a certain part of our body, except for in the therapy world at this point, we don't have specialists that are embedded within the academic system. That's more what happens after in their training and their supervision, but that's usually when people, if they're going to find a specialty, find it. But yes, it's being trained on how to treat a specific subset of patients with a specific set of diagnoses that are usually related, and they're treated in evidence-based, established protocols for training that disorder.
Yeah. Yeah. I think in a lot of ways, it's easy to think because we've gone through OCD, we specialize in it. And there is a difference between someone who is a lived experience advocate who can speak to their own experience and someone who, like you said, is trained to treat it. I know here at Know OCD, our therapists have to go through so many case studies. They have hours and hours. I've sat in on the therapist training, and it's very, very rigorous to make sure they understand not just OCD, but also things like co-occurring conditions. They understand how to make a differential diagnosis, like to tell the difference between some of these conditions and OCD, and they understand a lot of the intricacies of all the different themes that can pop up, and all of the different ways that we need to cater ERP to that. And then they go through supervision on a continuous basis. Like there's these weekly meetings of continuing to educate themselves. Like you don't just check off that you're a specialist and are done. This is an evolving space. It's important for us to evolve with science and to grow as science grows. And it's so important that we find therapists who actually know what it means to specialize in OCD, because I think that's the other part of it is a lot of times they might not even realize that it's not something they specialize in, because they heard in college, that, okay, OCD is obsessions and compulsions. So that looks like hand washing and fears around germs, right? They have kind of an understanding of the disorder, but maybe not all the intricacies of the different subtypes or the different ways that it can manifest or mental compulsions. And it's really easy to think you might be able to specialize in treating that. Through cognitive behavioral therapy is often like the first approach, and not realizing, the snappy rubber band when you have an intrusive thought, like not realizing that ERP is like not as broad as cognitive behavioral therapy. That's an umbrella that ERP falls under, and it is different, and it is specialized for treating OCD.
100%.
Yeah. Okay. So I want to talk a little bit about what like first line treatment means. There's a lot of terms that we use. We say gold standard, we say evidence-based, we say first line. And I think sometimes we throw these terms around so much that people don't actually understand what it means to be one of those things.
Yes.
Do you want to explain from the lens of research what those terms mean?
Yes. So to answer this question, I kind of want to give an overview of how research works. And it's a really complicated topic I could give like a 10-hour lecture on. But to summarize, research is a very, very long process, and people like to use that fact against research to, in a sense, talk down about it, saying that it's not keeping up with the times or it's always behind. The reality is research takes a long time because we have to do our due diligence of studying the same intervention, the same treatment in large groups of people in reproducible ways where this same treatment is studied in multiple settings with multiple providers at multiple institutions, and it needs to be validated in this exact protocol to then eventually be disseminated to people, because then it's operationalized and it's studied for its efficacy and its variability is accounted for. So
especially to a vulnerable population like those in active mental health crisis.
Exactly.
That's not just something you just want to throw something at without having gone through the due diligence of making sure it's something that is going to not only support them, but not harm them.
Yes. And it's so much easier for people sometimes to think about this in terms of medication, because I think it's more intuitive to people to think that we don't want to start consuming a medication that's going to, potentially alter our brain and how it works and the chemicals in our body and our entire physiology without rigorous studies of its safety, its efficacy, its variability in different populations, its overall efficacy rate, right? But the same thing goes for psychotherapeutic interventions. It's not a medicine that we're taking in our body, but it's also working on our brain circuits. That's how treatment works. That's how we explain treatment being efficacious in people. And it's, in my opinion, and in the opinion of many researchers, equally important to give that amount of rigor and need that amount of data and reproducibility for psychotherapeutic interventions like ERP and other upcoming modalities that we're looking at. So with that being said, with what research looks like, it starts from maybe case studies or maybe small implementations in controlled, approved settings, usually research settings, with people who are funded for research, hired for research. They may also be clinicians in this case, but they are researchers, to be clear. And from there, they eventually make themselves to preliminary trials and then clinical trials. And then they have to be, like I said, reproduced in other vicinities with other researchers. And eventually they are determined to be a part of a treatment algorithm that exists for a condition. And this is a long process. It's a thoroughly vetted process. No process is perfect, but it's as close as it can get to being as studied as possible before being released out, if you will, to phase 4, which is the colloquial term for into the public, into the community, to then in a feed-forward feedback way, then get the data of what this looks like out when it's released out into the public and see what the outcomes are because it's still being tracked. And then that informs back the updated protocol so that it's ever evolving and ever updated, but in a controlled fashion. And so in terms of using all the words that we were talking about and what evidence-based means, what peer-reviewed means, what empirically supported treatments means, evidence-based is a loose term that is used to talk about exactly what was said, the base of evidence that exists for a treatment. Evidence-based treatment does not equal a first-line treatment or even an empirically supported treatment that is part of a treatment algorithm for a disorder. And when I say a treatment algorithm, that's just fancy speak for basically like if you think of like a decision tree, and we can start with first-line treatments. Like if someone is diagnosed with OCD, you look at the treatment algorithm, and what is the first thing that you do for someone with OCD? You give them the first-line treatment. In the case of OCD, in terms of the APA, the American Psychological Association, the American Psychiatric Association's treatment algorithm for OCD, that looks like ERP and or medications. There are differing opinions on which one you start with, but ultimately the consensus is you start with one and add in the other. I know there is a good amount of data to suggest that ERP likely is a better first over medication, and then either adding if needed or not. But regardless, you go with ERP or an SSRI, and then from there, you augment treatment to second-line treatments, third-line treatments, augmentations, based on if the first-line treatment is not 100% remediating someone's symptoms. That does not mean that the first-line treatments do not have merit. It just means that there's a lot of variability between people. They have comorbidities, they have different physiologies, and that's why there is a robust treatment algorithm that has been built to account for. It's very much a logical decision tree. Yes, it requires clinician input and judgment in certain aspects of it, especially with diagnosing comorbidities and things that you were talking about with NOCD and what they're trained to do, which is amazing. But at the end of the day, the most responsible thing and evidence-based thing to do, if you will, is follow this treatment algorithm. And so an evidence-based treatment can be really anything that has a base of evidence. And there's a lot of modalities that have a base of evidence in any direction. But that does not replace the term I think people are actually trying to use oftentimes, which is empirically supported treatment. That is a part of the treatment algorithm that is involved either as a first line, like I said, or multiple lines afterwards. And that's really important to note because there are many treatments that have a base of evidence that are growing. But like I said at the beginning of this tangent, we need research to be robust and longstanding before it's implemented into clinical practice. It needs to be fully fleshed out and validated and iterated on and approved by different medical boards and psychological boards that look at its efficacy and potentially the risks and harms and make sure that it fits into the treatment algorithm in a way that's doing more good than harm. Nothing is perfect, but doing more good than harm. And that is why research exists. Research doesn't exist to give ideas potentially to clinicians, for the most part, of things to implement before they are fully evaluated and implemented into the treatment algorithm. I can say more, but...
No, I love that. And I think that one of the things that I find really fascinating about what you just said is the whole concept, I guess, to rephrase, something I find really important here is, again, that this is not just a treatment. This is not just something we're talking about. We're talking about something as serious as someone's mental health, right? Something as serious as OCD. So of any time that we really want to lean on the research, it's here, right? I think back to when I was just the most stuck, when I was first seeking treatment, and how lost I was and how much trust I put in my professionals, my therapist, to know what to do. And it's kind of, to break down what you said into layman's terms, it's like if you went into the hospital with a broken arm, the first thing they're going to try to do is set your arm and use a cast, right? There are people who need more than that, right? Maybe it's like, actually, we need to also, there's a puncture wound, we need to do stitches, or, actually it didn't set quite right, we need to break it again, try again, we need to, do some sort of surgery. Like there's all these other things that we might have to do if you break your arm. But we start with setting the arm and using a cast, right? And it would be irresponsible to do something else, to start with the surgery or something before trying the thing that works for the majority of people. And when we say majority of people, I think it's really easy for people to get caught up in those who are treatment resistant to ERP, right? Those who, ERP hasn't worked for. And I think I want to define actually what it means to be treatment resistant, because I know you mentioned people who have co-occurring conditions and other factors at play. Going to an ERP therapist once and not having a good experience does not necessarily mean you're treatment resistant, right? There's so many variables at play. Just as if you were going and getting your arm set, you might have a really bad doctor who doesn't know how to set arms, right? You might have a doctor who isn't factoring in all of the other conditions that you're dealing with at the time. Like there might be so many other reasons that a treatment doesn't work for you. And it's really responsible and ethical for therapists to start with the thing that has produced the best results and then cater it to those individuals before jumping to trying other treatments, right?
Absolutely. I think another example that came to mind is, actually, I'm a cancer survivor, so I can speak about this from personal experience, but I know anyone else can put themselves in the shoes of themselves or other people in their life who has cancer. But you have a type of cancer, and cancer is deadly and can kill you. If you go to a provider to get cancer treatment, would you want the cancer treatment to start with that has the most research, evidence, longstanding efficacy, and safety data in patients that a specialist would recommend and is trained in treating you with? Or would you as a patient prefer something that does not have phase 3 data, that is not part of the treatment algorithm? And I guess my answer is I'd want the original treatment. And if that doesn't work, and if I'm fully resistant, which is easier to say in biological terms than we'll get into what treatment resistant means for psychological symptoms, that of course there are, people are every day put into trials that we need and, given experimental treatments, but that's usually after not responding to the treatments that currently exist. And I would guess as a patient, you all also would want that order of treatments. But going to the definition of treatment resistant, I think that's so important to talk about because, like you said, there's so much variability in, I guess for now, if we're treated by humans and even their understanding of ERP and how much they've been trained in ERP, supervised in ERP, understand OCD, let alone ERP. Like the fact that OCD is not taught about properly, and I think it's a consensus out in the psychological and psychiatric community, both in medical school and in all levels of psychological care, OCD is not taught correctly in almost every institution. So we're already starting at such a loss in terms of understanding the disorder. I mean, as a patient who's been in treatment for active treatment for almost 4 years, I still barely understand my OCD. So it takes so long for a provider to even understand how OCD works and how it manifests the vast majority of themes and how heterogeneous, and that just means how different it can look in people, and the nuances of compulsions and mental compulsions and all those things, right? So first, they need to actually be trained in all of that, and then they need to do it well, which sounds simple, but that takes specialized training and evaluation and practice and supervision. And if you're getting ERP from someone who doesn't have that or did have all of that and just sucks, because let's be real, like there is a variability in any profession doing anything at all. That can all play a role in someone not responding to treatment, right? And it's so unfortunate that people, for any condition, especially with OCD and ERP, try ERP from someone who thinks they know how to do ERP or just sucks at it, and then they don't have a proper response and they think ERP doesn't work for them. There's also sometimes people who try it and it is difficult at the beginning because it is facing, your fears, and ERP is challenging everything about OCD. That's really difficult for anybody to do. It's worth it, but it's difficult for anybody to do. And a lot of people drop out at that time and also say that it's not working for them. And so it's really, really difficult to parse out, is the treatment not working or is the treatment implementation not working for the person? And so
can I just pause you right there to talk a little bit about the backdoor spike phenomenon that we experience with any sort of behavioral change? Whenever we're changing a behavior, there's this period where the behavior seemingly gets worse, or in actuality gets worse before it gets better, because our brains are going through this extinction burst of all of these, all of this stuff that we've been doing forever, this habit that's been keeping us safe according to our OCD. Suddenly we're not doing it. We're going to feel more unsafe for a while, right? And so I remember when I first started ERP, it was week 2, I was going for 3 hours a day, intensive outpatient, and it wasn't until the second week of treatment that I just felt like I am so much worse than I've ever been. And if I would have stopped there, that would have been my impression of ERP, was that it makes it so much worse, right? It's like if you were changing a toddler's bedtime because, they needed a better bedtime, the tantrums are going to get worse before they get better, right? It's going to be harder for a while until the new behavior cements itself. We've been digging this groove of neural pathways for so long. Changing it is not comfortable for our brains. And so I think it's really important for therapists to set expectations around that. In therapy of it's gonna feel worse, right? And then, we'll see how you're doing actually in 2 months. It's not gonna be some quick change. And I think that that's one red flag, that is really important to look for in a therapist. If you are expecting those quick results, the magic bullet obsession, the magic bullet cure, where you're that one thing is gonna make me feel better, or even if your therapist is promising that, it's kind of a red flag, right? If you're going to therapy and you leave feeling good, I know this is a controversial feeling that I've heard a lot of pushback on this, but if you leave your therapy feeling so positive and you have OCD, you might not be getting to the root of some of the OCD. You might not actually be challenging it in the same way. Now, you don't have to leave feeling in high distress. Sometimes you do, right? But you do want to be actually working through those big emotions. And that means therapy does not always feel good. Just the same way self-care is not always taking a bubble bath. Sometimes it's doing the dishes. Sometimes it's the hard work. And that might come up in therapy. So I just wanted to add that in there as some of that extinction burst that people experience. And then the backdoor spike when those symptoms start to go down and they think, oh no, does that mean I actually like the obsessions? And they come back. I think it's really important we normalize all of those phases of therapy.
That perfectly maps on to one of the main elements of OCD that we do understand is working in the brain, the circuit that is one of the main implicated circuits that drives OCD, and it's, in scientific speak, it's pathophysiology, because the idea of OCD, at least in part, is that we have an over salience of thoughts. We have intrusive thoughts. These thoughts.
Can you define salience?
Yes. We are giving attention and meaning and importance. Our brains think that those thoughts are important and they pay attention to them. And then they gate them as such that they are. Our brains are always looking for information that's important versus not. We're taking in information all day long. And we obviously, I don't think that the light over there is important, or I don't think your shoes are that important right now, maybe later. And sometimes our brains, perhaps with people with OCD, think things are more important than they are, / we are having more vivid, intrusive thoughts, and we don't know why. We're trying to figure out why.
So in other words, there's more urgency. If I'm seeing the sink over here that might have germs,
Yeah.
I might be having a stronger reaction to it because I'm thinking about the germs that are over there than someone without OCD who just thinks it's a sink, right?
Yes.
There's more of the urgency, more of my brain is signaling safety and survival is pending on that sink.
Or just importance, even just importance. And from that importance, we get to typically decide if it's actually important or if it's not. Like sometimes we hear a loud sound and then we realize it's not important and we go along our day, but we couldn't necessarily control if the initial sound piqued our interest or we thought was important. But for people with OCD, it's the thought and then it's everything that precipitates from that thought, right? It's all the actions that we take, whether they're mental or physical. But what that's doing is teaching our brains that these thoughts, that theme of thought or that urgency feeling of that thought is actually important. And then subsequently we do behaviors which are mediated by our motor systems, which include mental compulsions as well. And I think that's something most people don't think about, but thinking is a thought. Thinking is an action, right? So when we stop doing and to close out that circuit, that then feeds back into our importance center of the brain. That's very simplistic, but that then reinforces that beginning part, the cortical part of the cortical striatal thalamic loop, if anyone wants to look that up. It just reinforces that cycle and that maps right along the OCD cycle.
So I just thought about the sink. I've been thinking about it and my brain is giving more importance to it because I've been thinking so much about it. I'm actually avoiding it. I'm like not looking at it.
Which
and
is the
now
action.
My brain is learning there's something important about that sink. Even if there wasn't initially, right? I've just confirmed that there must be because otherwise why am I altering my behavior accordingly?
Exactly. And not only the sink, but unfortunately with the case of OCD, then anytime you feel that sort of feeling about anything that's not the sink, like the wall or that bag, it's going to do the same thing and generalize, which is why OCD latches onto everything and can morph and grow over time. And it's so, so fun. But the part that is really important in terms of what we just talked about is once you remove that behavior, that part of your brain that is used to the thoughts and the intrusive thoughts, the vivid nature of the thoughts and the feelings, that's not just stopping. In fact, compulsions serve to temporarily alleviate the discomfort, the distress, the anxiety, disgust, like whatever you're feeling of the obsession, right? And so when you take away the compulsion, what happens? You feel the distress more. That's literally the point of treatment, but a lot of people interpret that period in which they feel that excessive amount of discomfort, whether it's, right during the exposure or in general, as they might compulsively ruminate about that later, like that discomfort stays until we learn how to tolerate it, because it's not necessarily the discomfort that's just going away on its own. It's us tolerating it and then interrupting that biological cycle. And unfortunately, like you said, people often conflate that as I'm just not getting better. It's not working for me. Like this is years and years. And honestly, in terms of like our evolution as humans, like, eons of our brain evolving to keep us safe. And it doesn't change overnight and it doesn't change the activity. What we're trying to do is interrupt that cycle so we don't automatically just do behaviors in response to that. But it doesn't mean that the thoughts and feelings still aren't there.
Yeah. No, I often tell people that ERP in some ways, I know it feels intense and you're doing a lot of active work, but in some ways it is more passive than we might think. It's a lot of non-engagement and not doing things than it is about actually doing things. Right. And our brains don't really like that. We would rather do something, right?
Yeah.
And so some forms of therapy, going back to the sink example, I'm not actually thinking about the sink. I just it's like right in front of me. But I might go to a form of therapy that's all about, let's figure out why you're thinking about the sink, right? Let's like sit here and we'll like ponder and think about it and we'll try to figure out exactly why the sink is so important to you. Like, what is the fear? Let's get into it more. Let's talk about it. Let's sit here and let's talk for 30 minutes about why I keep thinking about the sink.
About it.
Right. And all that's doing is adding the salience to that thought. It's just telling my brain, this is important. Wow, that sink really, there's something to that. Maybe I'm snapping a rubber band on my wrist and it's just teaching my brain every time I think about the sink, there's something important that's happening.
Thus I have to
do this, right? Or if I'm stopping the thoughts, which sometimes, forms of CBT might teach you, let's just, cut them off. Let's block them out. I'm still teaching my brain it's important because I'm trying not to look at it. I'm trying not to think about it, right? And so real recovery looks not like doing anything. It looks like allowing the sink to be there and noticing it and feeling the distress, But the cool thing is that distress does die down over time, and it might take a while. And we might learn sometimes it's not just about the habituation. We might not just have the distress go down. We might also learn how to tolerate it, which I think is the coolest part about ERP, and the part people sometimes miss is ERP is life in so many ways. Like distress, I always tell people, even after you graduate ERP or even after you're done going, there's still going to be traffic. In other words, there's still going to be things that you hate that you have to learn how to tolerate. There's still going to be anxiety. There's still going to be fear. There's still going to be shame, guilt. All these emotions are very human.
Yeah.
And so it's about actually allowing them to be there, not about trying to solve them away. So many of us like start therapy with this idea of like, I just want to get rid of the anxiety. And while it does dissipate, right? Anxiety is part of my life. It's always going to be. It's part of life, right? And so I actually want to learn how to sit through that, not just get rid of it. So I want to talk a little bit. We've talked about a lot of these concepts around therapy as a whole. I want to talk about therapists. We've both had experiences with really bad therapists, so let's start there. But then, so we don't leave people in like this hopeless feeling, let's also talk about our favorite therapists. But let's start with like, what are some red flags people can look for in an OCD therapist? Share some of yours. I'll share some of mine. What are some of your experience with therapists, and what red flags should people look for when finding a specialist?
To clarify, is it when looking at any specialist or someone who specifically says they're an OCD specialist?
Let's say someone specifically says they're an OCD specialist.
First and foremost, if they have multiple, like many modalities listed in how they treat OCD, and number one, ERP is not one of them, that would be a massive red flag to me, because how would that not be? It's the first line, treatment in the treatment algorithm for OCD. But also, there aren't a whole lot of specialized treatments that are evidence-based, empirically supported treatments that are in the algorithm for OCD. So that is a really easy way to weed them out, because they're usually listed on their website or their profile or anything like that.
Which, let's talk a little bit about that one. So I think that it's really important to recognize that while ERP and medication, as you mentioned, is the first line treatment for OCD, there are definitely modalities that can help support that, right? ACT is a really great modality that sometimes some of our therapists at NOCD use to support some of the work we do in ERP. Like there are some modalities that can be a great service to you, including when you have co-occurring conditions, right? Then therapists do need to get creative with more than one modality. There's a difference though between using ERP as the first line treatment and building in resources to support that, and support the individual, because that's really any therapist's goal should not be to treat a disorder, but to treat an individual, right? There's a difference though between doing that and just like trialing different modalities that have not been studied to treat OCD. There's a reason that therapists don't go purely off, or shouldn't go purely off, anecdotal evidence or what they've like seen work sometimes, as you mentioned, because while we're treating individuals, it's also so important to look at the actual psychology of the disorder, right? And do a lot of psychoeducation around the disorder itself and why that particular treatment should help you. If a therapist can't describe to you exactly why that any sort of therapy should help your condition, they should not be doing that form of therapy.
This is why we are best friends, because literally that was the next thing I was going to say, which is like, to me, another red flag is if the first treatment that is not tried for OCD at its base is not ERP, because that is the psychotherapeutic modality that has by far the most, not only the most evidence and the most research backing it, but is listed and established by entities and providers who are in positions of power to determine this as the first line standard of OCD treatment. And that is very important to say, because like you said, there are adjunctive therapeutic modalities that are empirically backed and part of the treatment algorithm to incorporate as adjunct to OCD treatment with ERP. And that is different than emerging lines of research, of which there are many across psychotherapy, neuromodulation, medications, psychedelics, which are considered maybe a different kind of medication and intervention. There are many lines of research going on. They're not necessarily part of the treatment algorithm. So there's a difference between emerging lines of research that have an evidence base, as opposed to things that are approved to be a part of the treatment algorithm, whether they're first line, second line, third line, whatever line treatment. So to me, because of how OCD is studied and conceptualized and the decades of research backing it, of course, no treatment works for everybody, but the most responsible, ethical thing to do that is established by powers that be that are not me, this is not just my opinion, this is what is considered to be the ethics of treating a disorder, is starting with the first line treatment, which is ERP. And so to offer multiple modalities of treatment as options, that just is not reflective of where research and the empirically supported treatments for OCD is at this point. Maybe one day, but that's not the case right now.
Yeah. And you and I are both very open-minded, and we love like alternative concepts and have incorporated some of that in our own healing and our own recovery, right? And still would always recommend that as the first line therapy, right? We want therapists to be able to work, again, with the individuals, not just the conditions. We want them to be able to factor in your background and your identities and all of the other ways that you are a human outside of OCD. But it is so important that, you know, before a therapist dunks your arm in Listerine, they set the broken bone, right? They do the thing that we know works for the majority of people that is ethical and responsible. And I think that's another red flag that I look for in therapists, is ethical marketing. The way that they promote any sort of modality, any sort of therapeutic practice. It's so, so important. You look for words like cure. If they're promising a cure, anything quick, any quick fix, if they have a set timeline. I don't know what your recovery timeline looked like, but I can immediately guess that they were different for both of us. Like, I think that it is so highly individual. It's really, I would not feel comfortable with a therapist ever giving a direct timeline for how long it will take you to recover, right? Yeah, we really want to be looking for any sort of promises that therapists might be making, because again, you are not a statistic. Even if you have OCD that we've studied so much, you're still an individual, and it's really important that therapists know that as well.
I think the one thing I'd add is I think it's valuable if a therapist especially is more research minded to be quoting like the data as such. Like if someone has a question of how efficacious ERP is and, you know, the stats around how many patients tend to respond versus don't, that's not necessarily telling the patient what their outcome is going to be, but it is helpful. If anything, I think it's a green flag to be honest about the fact that not one treatment at this point works for 100% of people when done to fidelity. And that's okay. That's why we're researching. That's why I have a job. I mean, that's why I'm getting a PhD and studying OCD every single day, and why I've been told we're all, if anyone wants to join the field, please do, because like we're going to be employed for a long time because there's a lot of work to do. But all that being said, I do think it's important to be honest about the stats. But yeah, to your point, it's not, to be so clear, it's not responsible to offer other modalities of treatment that are not supported by the vast majority of research.
NOCD is really, we're always looking to expand and always looking to grow. And we add new trainings all the time. And we think, oh, here's this other co-occurring condition. We want to do more training in this area. Like, it's so important for us to be growing in those ways. And also to publish the studies. Like when we do research, we're honest about those numbers because people do deserve to know what it is they're getting in for. And I think there's a difference between setting expectations and, you know, showing what works for the majority of people and talking about the statistics and like promising a cure, right? Very, very different. And so any language in that realm, any sort of promises, I think it's really important to look out for. I think it's also really important to talk to your therapist even before you start therapy with them and ask them again, like, why do you use these modalities? Why ERP, right? Like, tell me why that actually can help. And I think a green flag in a therapist is if they sit you down and do a lot of psychoeducation before they even get into the nitty gritty, right? Because I really feel that is a very important part of ERP, is knowing why it works. Otherwise, it just feels, it's not really an exposure if you're not opting into it, right? And so knowing why we're doing these things is really important. And a therapist who can describe to you why OCD is operating in that way that you described, right? The confirmation of the threat and the way that all operates is really, really important to look for. Do you have any other red flags you want to talk about before we touch on our favorite therapists?
Yes. The reason I want to emphasize offering any other form of treatment alongside ERP as a first-line option as something being a red flag is because that's just not rooted in the science. And I think what's really interesting about our community as someone with lived experience is that we are we're suffering deeply. And even when we are in our journey of recovery, our community is really, really passionate about dissemination of OCD advocacy and resources and evidence-based treatment, because most of us were misdiagnosed and mistreated, and we reaped the unfortunate consequences of our system. And because of that, we're always looking for ways to spread the word about treatment and what exists right now. And amidst that conversation, what often happens by accident is talking about treatments that are in its infancy of being studied. And there are so many nuances to, like I said at the beginning, a treatment getting to a point of it being responsible to disseminate to the public and for a therapist to offer as a first-line option alongside the established first-line option in this case, which is ERP. And to be so clear with you, to not mince my words, there is not another first-line treatment that has the robust evidence base that's part of the treatment algorithm psychotherapeutically at this time. And unfortunately, a lot of information is being talked about in an inaccurate way with the best of intentions, because words like evidence-based are being spread so often and talking, it's conflated that if there is any published research on any element of a new modality, whether it be medications or treatment, that it's an option. And oftentimes those are used as compassionate last resort options for people when they're not responding to literally everything on the treatment algorithm, and that includes deep brain stimulation surgery and ketamine. So with that, if you're hearing of other options as first line, I encourage you to ask questions. And unless you're vehemently against doing ERP, which please do your research and speak to professionals to come to that decision on your own, although I respect people's autonomy, there is no reason to not start with ERP as the first psychotherapy modality. That is my opinion, and reflected by what I have learned in my training so far.
Yeah. Well, and that goes beyond opinion. That's just where the science is at currently, right?
Yes.
And I think that it's so important to recognize as well, something that's so unique about the OCD community is the fact that so many of us are advocates.
Yes.
Like the OCD sufferer to OCD advocate pipeline is really strong. And I think it is a really unique facet of our community, the fact that at the International OCD Foundation Conference, there are lived experience advocates presenting alongside therapists, presenting alongside researchers. That's really fascinating. And I don't actually know so many fields that have that space, right? And I think that there's so much beauty to that. Obviously, that's how we found each other. Like, that's why we love this. But also, it means we do have to do our due diligence in recognizing that not everyone who speaks on OCD is an expert. That not everyone who even has OCD or even treats OCD is considered an expert. And so I think it's really important that we look for those, social media marketing, like gimmicky marketing, like anything around this topic with a lot of scrutiny, especially because as people who have struggled deeply with OCD, we know how vulnerable you can feel when you just want to get better.
Yes.
And you would give anything to get better. And so when we see people maybe promising like a brain scan to diagnose, which we don't have the science to support being able to do a brain scan to diagnose someone yet, right? Like when we see some of these things, I know both of us get very protective of this community because we understand how much I would have loved to have someone prove to me this wasn't all something I was making up, that this was real, right? I understand the pull into that. And that's why I think it's so important we protect the community as advocates, that we, speak up when we're noticing these trends and these different concepts that might have worked for some people, but the evidence and the data just isn't there yet. Even just adding that word yet, I think is important because we're all about finding new treatments and finding more ways to treat those people who are treatment resistant, right? But the data's not there yet.
I just really want to say, without getting too emotional, that I know that especially as I'm speaking and I'm getting all into research land and lingo and all the terms, that's from my developing expertise as a scientist, because that's what I do. But the reason I do this is because I have lived experience, and the reason that I'm so passionate about teaching and educating other people on these concepts and these fallacies and the way that people like me, I have been one of those people that has been victim to misinformation, and I have lost many years of my life and a lot of quality of life as a result to it. And that's why I do the work that I do. But as someone uniquely at the intersection of having lived experience and fully being in this community and being someone, which you were talking about treatment earlier, I am still in treatment twice a week with my amazing therapist, who we'll talk about later. And I'm living this life every single day. I am apparently on the lower end of severe now, which is a win for me because I'm taking longer treatment. That's just how my life is, and that's okay. ERP still works for me. But the reason I'm so passionate and the reason we're talking about this and why I'm so stubborn when I say all these things is because I see on a daily basis how much people are taken advantage of or just fall prey to misinformation from people who either at the best of it have good intentions but are just spreading misinformation because they themselves are misinformed and then it catches on, or at the worst case, they're trying to sell something that is taking advantage of people. Take brain scans or any cure for OCD that seems to exist, or, people are spending all this money to try to find biomarkers by like ordering some sort of kit to their house, and then they get some magical report that confirms to them indeed that they have OCD because of this gene or this thing. Like that's not where we are at. People like me are working to develop that, but we're just not there. And maybe a rule of thumb is if you don't, hear about this from your provider or from your, licensed clinician or your psychiatrist or anything, like likely it's probably not real. And it's really hard to hear that because these sound like exciting new innovations, but like they're not evidence-based. They're not empirically supported. And so that's the worst version of taking advantage of people. But then on the other side, like we were talking about, like when misinformation spreads about where the state is of research for a certain modality or treatment, it's oftentimes actually just an issue of scientific literacy. Oftentimes people take a paper or even a set of papers and take the abstract or one sentence or one statistic and they think that that's true, and then that spreads rampantly. Or people think evidence-based means like having any evidence at all, or even, clinicians, one element of people's scope of work. Like I am a neuroscientist. I work with biological data. I understand how research works. I understand, genetics, or I'm continuing to understand that. I understand how to read research. That's my whole job. And I understand how trials work because I do translational psychedelic research and basically implementing drugs in people. And that's my expertise. My expertise is not being a therapist and understanding how to apply and do ERP, for example. I'm a patient and I'm the expert of my own lived experience, just like we all are. But I think, like you were saying, lived experience perspectives are so incredibly important. Obviously, that's what I advocate for. But that's not being an expert at everyone's lived experience. That's a different skill. And in terms of clinicians, there's a wide variety of clinicians and their scope of work. And what's really important to note is there are some clinicians who are either physician scientists, MD, PhDs, who are trained in being a provider of psychotherapy and medication and doing research. That's embedded in their scope, and they're able to speak on and study and talk about both of those things. That's a rarity. Clinical psychologists, for the most part, not always, but they almost always are trained in doing research as well as doing psychotherapy, and many of them run their own labs and continue to be a scientist as well as be a psychologist. Those are two different skills that they both have, and that is valid, and they're qualified to talk about it. Other than that, typically master's level clinicians are obviously clinicians, and they are qualified to, and their scope of practice is to treat, but not to study the condition. And that's really, really important because oftentimes we're looking at anybody who has a credential in doing therapy or doing treatment and seeing them as a voice of expert who can speak about the state of research, who can understand statistics and literature and what peer review means and how to publish. And that's just not their
And the
expertise.
neurobiology.
No, I didn't even get into the neurobiology, but even especially that's not part of what they're trained to do. They're not trained to evaluate or disseminate research, nor are they, trained to conduct research. And so, there's always exceptions to the rule, but for the most part, that's not part of their training. Thus, the issue is people in our community are, of course, we respect and care about therapists so much because they are the people we're interfacing with for the most part to save our lives. But when they're not qualified to speak about something, but they are because they care so much, often they themselves have lived experience, that's an example where they have the best intentions, but it's going wrong and it's causing harm because it's spreading and implementing treatments that are not supposed to be implemented right now.
Yeah. It's so important that as advocates, as therapists, as researchers, we're honest about what we don't know. That is the ethical thing to do, is to know your realm of competence and where it ends, and then to defer to each other, to work hand in hand. And I love that you brought this up, because I think, someone listening to this might be like, those girls are real cranky about, like, very, very passionate about this topic, but there's a reason. It's not just that we like hammering facts all day. And if there's passion behind what we're saying, it's because it impacts people like us. It impacts people like our former selves. And I think that it's really easy to get caught up in the world of advocacy and kind of forget some of the reason we got into it to begin with. I remember I met you doing a commercial with Biohaven and Ethan Smith, and Ethan, as the wonderful director and person he is, really encouraged us to get into the emotion of having OCD. And like, he was like, turn off the advocate, like the bright-eyed, bushy-tailed, like, let's help people, turn it off and just like feel back to why you started doing this. And it took me a minute to get back to that emotion and remember, how bad it was, like how truly horrifying it was when I was struggling with the clinically extreme OCD, when I felt just completely stuck. And I think that it's really important as advocates we don't forget that piece. Like, it's so great that we get to fuel this into our work, for a lot of people, their livelihoods, might be directly working with the OCD community. And I think it's easy to get caught up in, like, people might get caught up in like following numbers and how many people are reading this and how can I help these people. And it's so easy just to like move forward and overpromise or overcommit and just jump into every opportunity to advocate. And it's because we care. Like, none of this conversation is about people not caring. Right. People care deeply and they want to help. And a lot of times when they're speaking from that personal experience, they have an extra like added component of emotion behind what they're doing. And I think it's important we stay true to that we like touch back within ourselves to that space where, we are and have been really vulnerable, and really susceptible to marketing and things because of the OCD, and susceptible to promised cures, and are really mindful of the language we use when we talk about things like ERP, when we talk about things like other treatment modalities, when we get excited about new research, that we remember the population that is listening, and are really, really mindful about the way we disseminate that information, and where it's not our scope to disseminate that information, and leave it, there's so many things I leave up to you as a researcher that is not my scope. And so I love that you mentioned that, because it really is why any of us are doing this work, right? Is because we care.
And I just want to add that nobody is trying to gatekeep this information or gatekeep research or trying to, claim expertise over something because someone else is like, it's not a competition. The reason that I'm focusing on and honing in on this so much, it's not just because like I like sitting here and complaining. Like, the passion is so palpable and real because this is me coming as a lived experience advocate, and there is such importance and expertise of people's emotions and their lived experience, and that is enough to raise awareness for the realities of this disorder, how misunderstood it is, how stigmatized it is, how painful it is, and why we not only need to raise awareness for how to treat it, but also, full circle, that lived experience helps raise money and dollars for more research, which is what we need. So your expertise is important and valuable and does not need to take it, it doesn't need to be legitimized by talking about things that are not part of your lived experience. Like, as someone with lived experience, that's typically where I stop in terms of sharing what I've done and what's worked for me. And I then have to transition to research hat, which I'll never separate. And I'm very proud of that, in that I study and research OCD because I'm aware of how much it impacts me and other people and why we need more treatments. But I can't come into research like excited to figure out how something works. The question is if something works. And I have to be okay with whatever result, no matter how I feel about it, no matter how that impacted my own life and how wholeheartedly I own that it may have, in my story, made a difference. That means absolutely nothing in terms of its efficacy when we're studying it in research. And that's what's so important to parse out, again, with like lived experience versus empirical data. And that's not invalidating everybody or anybody's lived experience. That just means that's not generalizable to the public. And yeah, I just want to emphasize that like it's it's okay for something to work for you and not for everybody else. And that's not a threat to your lived experience. But at the same time, it is irresponsible to say that it's going to work for everyone or everyone should try it just because it worked for you, if it's not something that's been adequately studied in a larger population.
That is so well said. So well said. There are so many things that I've tried that were helpful for my OCD at various points that I don't disseminate to the general public because I don't know that they would be helpful for everyone, right? And I think it's important to learn those lines between the personal experience and what has been studied to help more people, right?
And we're meaning-making machines. Like, for all we know, like, the reason research is done in a double-blinded fashion, for the most part, is because we have the bias within ourselves to have, for example, taken something or tried something, and then we get better and we think those are related, and they may be not. But that's why we have to go prove it in settings where we don't know what we're taking or what we're receiving. That's the point of blinding, which is a whole other conversation. But that's why there's a difference between lived experience and research.
Love that. So, okay, I know we could talk all day long. But let's wrap up here and talk a little bit about our favorite therapists. In closing, do you want to tell us about your favorite therapist? Because I want people to know that there are therapists who care deeply about you. One thing that I've really appreciated here at NOCD that Stephen Smith often says, who's the CEO and co-founder, is he'll often say, even if people don't get treated here, I just want them to know they can get treated. And I really felt that throughout working here. The mission is beyond just the work that we do at NOCD. And I feel that as an advocate too. Like, I hope that I'm able to separate my own biases and my own personal vested interest in people getting better and just help this movement as a whole. I know you mentioned like us not being in competition, right? And I think that that's a really important thing. I also want to just chime on here. It's so important that we recognize we have a higher goal. We just want people to get better. Yeah. And so even people who, might not always like lean in the way of research or might not always say the perfect thing, like everyone is wanting people to get better. And I think that is such a valuable thing. So I just want to mention that as a message of hope. And then separately as a message of hope, I want to talk about the specialized therapists that we have found so that people know that is an option for them.
I want to say something to the first point before, which is that I'm just going to say this because I don't work for an OCD, but none of us are getting a commission from ERP. None of us are getting paid from ERP. We spent all this time in this episode talking about ERP, not because we love it because it's ERP, but because it is the first line, most supported treatment for OCD, because we care about treatment for OCD. My literal job is to find other treatments for OCD. Yeah. And because I'm focused on the patients who are not helped with current treatments right now, and two things can coexist at once. And so that I just want to really get out there that my enthusiasm for treatment is because of how many people it's helped, and we're looking for different and better as well. So, and NOCD literally just wants to help people with NOCD. So take that as you will.
I've heard NOCD, like various like staff members, I think in particular Patrick McGrath, say a couple times, like if something new came out tomorrow that was proven better, we would do that. Yeah. Like that, we want people to recover from OCD. Yeah. And you said this earlier, like we're NOCD, we're not ERP co.
Exactly.
Like there's a reason we choose to treat with ERP, but we really just want people to get better and to know that there are options for them. And that includes within the realm of ERP. Like it's not one size fits all either. That's one thing we really impress upon our therapists is it's not just like, here's the list of exposures you go do for everyone because everyone's OCD is the same. It's like, there's so many back and forth discussions of like, hey, this member has this particular variety of OCD that we want to really target. What does that look like? And there's brainstorming sessions between therapists to really make sure we're catering the ERP specific to that person's obsessions and treating their OCD in tandem with them, right? It's like them and the therapist should both be working on the OCD. And in that way, it will never be one size fits all. So I think like as much as we want to diversify what treatment looks like, we can also do that within the containers of what we know works, right? We can diversify ERP, and we should make sure that it is, very applicable to all the different individuals who come in to seek treatment. We should make sure that we are factoring in people's identities and, experiences and backgrounds and co-occurring conditions as we look at treatment modalities. And I think there's room to do that within the current body of research that we have.
Absolutely.
And we keep looking to expand, as you mentioned.
Yeah, it's kind of like a cake. Like a cake is made with basically the same formula and ingredients at its core, and then you can tailor it to whatever flavor you want. You can adapt it to people's allergies if they have it, but you have to be trained in how to bake and understand the fundamentals of how baking works, aka how ERP works in its bones, to true treatment fidelity and how it was researched, to then adapt it to people once you have the bare bones of it. And that's why, if that much training goes into training specialists at NOCD, I mean, full circle, that's why we need specialized treatment for OCD. So that's why specialized treatment is so important. And that leads me to my favorite therapist. And I have two. One of them, so I've had 3 ERP therapists for a variety of reasons of, honestly, insurance lapse and coverage. But my current therapist, her name is Dr. Carrie Brown. I'm going to give her a shout out. She is someone who has, I'm going to say, helped me save my life, because I'm learning from her not to give my power to other people, but she's helped me save my life and live a more beautiful life than I ever thought possible, and has understood my OCD from her expertise and training in ways that I still don't understand as well as she does. And it's even just in I've been in treatment for almost 4 years. And even in the last month or two, the exponential gains I've made and being able to not white knuckle and ruminate as much, which sounds very simple, but is something I've struggled with my whole life, and that has debilitated me and kept me from really experiencing life. I can't believe even this level of recovery now I get to live. And that's contrasting from, and if you'd listen to the other episode I was on in the podcast, where I talk in depth about being a college dropout, being housebound, and barely being able to function, let alone live. And I'm just so grateful for her compassion. And she's someone who I continuously tell her new intrusive thoughts that I'm afraid she's never heard before. And and they're very, very niche intrusive thoughts that especially as an OCD researcher who works, for example, with animals, I thought no one else would have ever said to her, doesn't ever bat an eye. And so even just that compassion and that acceptance helps destigmatize the taboo thoughts I have. And the amount of compassion she shows me, even when I'm still doing compulsions and I'm not able to fully do response prevention in the way that I hope to do one day, it's transformative. And so I'm sharing that as an illustration of the messy middle. I'm not an example of perfect recovery, and that's okay. You can still live a life and be in treatment. So thank you, Carrie, for being that person who's given me faith in recovery in ways I didn't know I could have. And then the other therapist is actually not an ERP or OCD specialist, and I've seen her for the past 5 years and still continue to see her because she helps me Carrie treats my PTSD and OCD. And then my other therapist, Dr. Catherine Keller, treats my PTSD and being in a religious cult, which is a whole other experience. And the reason I appreciate her so much is from the get-go, she's been with me through my journey of getting my diagnosis and my treatment of OCD, and she has never strayed out of her scope. And that has been so helpful for me, because even when I didn't have OCD treatment and I was in between therapists, she was able to support me in a way that never reinforced compulsions, because she went and learned how to do that. And no one's ever perfect, and it required me being aware of it too. But she was so curious and accepting, and never ever tried to assert that she could train, or that she was trained to treat something that she wasn't. Even if she went and sought out education for me, that was, as someone who understands how research and training works, she would never claim to be an OCD expert or specialist when she's not. And so that has worked so well for me and has garnered so much trust in her ability to see me, because even if she doesn't understand everything about me, she's able to respect that and learn and not harm me in the process, which allows me to continue to still work with her on things like being in a religious cult. So I'm really grateful to both of them for their respective expertise.
I love that. And I love that we're the same person, because I also had 2 therapists. One is my current therapist, who is basically the exact same as yours, who works with me on the PTSD and the religious side, and helps with knowing her scope, knows exactly when something is more OCD that she's admitted she's not trained in, but she has a really deep knowledge of, and is able to say, oh, that might be OCD, is able to flag it, but then not do, not dive too deep into it or do the exposure or response prevention because that's not her specialty, right? And my first therapist was my first ERP therapist, who was so tough on me because she had OCD too. And she knew what that looked like. And that's not a requirement. I have had great therapists who have not had OCD. And I appreciate, I appreciate having the external insight. But I think what was so powerful about her to me was she pushed me with ERP. And I didn't know I was that strong. OCD had really beaten me down to a point where I thought that self-care and self-compassion looked like taking the easy way out a lot of the time, right? Like I mentioned that earlier, like thinking self-care was like bubble baths when really it's doing the dishes, right? So often I think I thought OCD was stronger than me. And there were so many things that I thought the compassionate thing to do was not to face. Like it was kinder to myself and I needed to avoid, right? And she was able to say, no, like actually you are much stronger than your OCD and you can face far more than you think. And I think that's something that's so undervalued in an OCD therapist, right? Not only do they have the insight and the outside perspective that you might not have when you're in the midst of OCD, but they also have insight into your strength and capacity that you might not have when you're in the midst of OCD. I did not know that I actually was strong enough to face the anxiety and I was going to survive some of those things that felt like I just could not. Like I did not want to touch because there was no way I was going to make it out the other side and be okay. And I did. And I think so much of that is because I had that therapist who was like, oh, no, I know you want to talk and get reassurance right now. That's too bad that I can't. Like she was so brutal and I love her for it. There were some times where I was like, oh, just make a note on that exposure. Like that I just like, let's soften it. Let's get rid of it. And she would be like, sorry, I'm having a hard time writing. Like I just can't. Like she just would not give in to my OCD. And it was the kindest thing someone has ever done for me, even though at the time I was like, she is so rude. She is so mean to me. I didn't realize how kind it really was. And so, we just, in closing, want to offer that there are ERP therapists who are trained to help you with OCD. There is hope out there. There are therapists who are able to give you the insight that you might not have. And our hope would be that you're able to look for those therapists and to feel empowered to find them. The Know OCD Game Changers directory is a really great resource to be able to find therapists. Here at Know OCD, we have so many really wonderfully trained therapists who specialize in OCD. The IOCDF directory is another place to look. And of course, you always ask questions because that is not as vetted as some of these other platforms, but you always ask questions with those therapists. And there are therapists who are able to help where you're at in OCD. And we just hope, if anything, I'll share what I hope from this discussion and you can share what you hope. But I really hope, if anything, you leave this discussion feeling like there are more options, even though it might seem like we funneled down some of the noise. I hope it actually empowers you to take your recovery into your own hands and to know that there is research that is working to support you, and that therapy is out there and recovery is out there.
I hope that more than anything, you feel like you have hope. You have hope to break from how horrible this disorder can be. As someone who still lives with it every day, this disorder can warp our minds and it can feel like treatment won't work for us and that we're not worthy of treatment. And even the most specialized treatment, we're the exception to the rule. I have felt that and I still have intrusive thoughts about that some days. And I'm grateful to myself for not quitting. And I hope that you give yourself that compassionate chance too, because you deserve it. You deserve it. And not only that, in the best way possible, it's not about you and how you feel. There are lots of people that are not you who are doing this work to validate and research and come to the best possible options to help support you in your treatment. I know, like Tia said, we sort of narrowed down what's the most responsible thing to start and try from, but just be rest assured that there is so much expertise and understanding of you and your condition with OCD, with your themes, with your compulsions, with all the things that go into this treatment and adjunctive treatments, and that there is hope. You do not have to live with so much fear and pain. And if I can do it, if Tia can do it, you can do it too. And lastly, I also hope you come away with a little more understanding of how research works. And I know it sounds complicated. I know it sounds thorough. It's okay if you don't fully understand it, but the whole point is for you to just know that there's a lot of people doing this that are dedicating their lives to this. I do that with my life. And if you want to, I welcome you to as well. But there are people who have your back, who are looking at this, who have the best of intentions. I'm one of those people.
Beautiful. Oh, thank you so much for being here, Uma. I love the way you verbalize my brain for me so I don't have to.
That's what I thought about you the whole time. Like, why am I even here?
Dream team. I'm so glad we got to chat about this. And thank you all for tuning in. Please subscribe on our YouTube channel to the Get to Know OCD podcast, and we will see you next time.